Well, good morning, everyone. I'm very, very pleased to introduce our first panel. As you recall from the earlier comments, we're going to have 4 panels. The first will be this morning, and the other 3 will take place during the afternoon. This one is about health and healthcare in the year 2020. And I'm very, very pleased to introduce the moderator for our panel, who needs no introduction, Don Berwick, the founder of the Institute for Healthcare Improvement, the former administrator of the Center for Medicare and Medicaid, is someone who has had an extraordinary career. Now, I have to say, in introducing Don, there are 2 things that I think are notable that may not be so well known. One known only to a couple of people, and that is many years ago, like 40, he and I were residents together at Children's Hospital in Boston. And we got off to an interesting start. One of us, he did extraordinarily well. The thing that I would have never known at that time, anticipating Don's luminous career, is that he would be named, and I want to get this correctly, an honorary Knight Commander of the British Empire, so named by Queen Elizabeth in commemoration of all the work that he did for the National Health Service. So that's an extraordinary title, and it's also, I think, important to remember that when the Olympics took place this summer, one of the things that London celebrated was the National Health Service. So Don, I think that's a great celebration for you, for us, and thank you.
Thanks, Phil. It's an enormous pleasure to get to join you, like so many colleagues and friends here, and my friends on the panel, and I'll get right to it. I'll just make a couple of very quick framing comments, and then leave it to the panel to carry the ball, and we're going to try to leave a lot of time for you in questions and answers. Just a little background. The background was beautifully set by Harvey and Julio both this morning. I could not think of 2 more pertinent framing presentations to inform the panel and the rest of the day. We're the sort of crystal ball panel. Right now, of course, in the U.S., things are very fraught. We are in a time of immense economic pressure, unprecedented in many ways, both in the public and private sectors, reflecting the global recession economy. This would be a very daunting set of circumstances for even a unified civil society and public to address. Very hard problems to solve, but it's confounded by this period of also almost unprecedented political polarization in the U.S. Tremendous amount of conflict, not just marked by the presidential election season, but really quite chronic of the past several years and probably for a few years to come. This is producing a sense of confusion in the public. Their leaders are in combat instead of sitting down together and figuring out what to do about these tough problems. And it has the side effect that the authentic dialogue that you might expect in public policy in the U.S. is a bit chilled right now. One of the side effects is that critical issues become third-rail issues, and in the political arena, it's not possible to address them with maturity, mutual respect, and the searching inquiry that you heard so beautifully illustrated by Harvey and Julio this morning. Optimism is in short supply, and the professions are confused as well. It's a very tough time. It's sort of occurred to me since leaving government last December that is a call to civil society. When government is a bit stuck, it is the civil society engines that need to get going to continue, restore, improve civility, trust, knowledge, public optimism, and to show a capacity to tolerate ambiguity, because these are hard problems. We're not going to have simple solutions. So it's such an honor and a pleasure to get to be with IOM, which I think is one of the pinnacles of civil society in America in its ability to engage tough issues with mature dialogue. And that's what I think this day is about a very set of tough issues around preparation of the workforce. It is one of those issues which can invite tremendous amount of rupture and tribalism, and we need a context like this one to explore together what should happen. This panel is assembled to explore tectonics, to help inform the rest of the day with understandings about the challenges that should be taken into account as we try to set sails for the healthcare workforce that we want for the future. In a way, the panel, this is a panel about prediction, not prescription. I think we've challenged ourselves to answer a question, which is to predict 3 properties of healthcare delivery or demand, either delivery or demand, that are changing and that are going to represent new challenges for those who are preparing the professional workforce of the future. As I was reading the charter, which we've discussed in several phone calls, I remind myself our job is not just to predict the future, it's to create the future. And I think that we first must take cognizance of the realities that we're going to face. This is particularly meaningful to me right now because with my colleague Gail Walensky, I'm currently co-chairing the new IOM committee on GME funding in the United States, funding and accountability, and I'm going to be a very good consumer of what this panel is going to be saying about the context to which we have to adjust. We're going to try to be very rigorous about use of time. Each panelist will have 8 minutes maximum to set out their first thoughts about the answer to that. What are the 3 challenges they want to talk about? There'll be rewards for 7 minutes and a big prize for 6 minutes. We'll then have some dialogue as a panel for just a few minutes, and then it goes over to you to ask us the questions that you would like us to explore. We have a fantastic group of panelists today, colleagues of mine all. Fitz Mullan, on your right, is the Murdock Head Professor of Medicine and Health Policy at the George Washington University School of Public Health, Professor of Pediatrics at GW School of Medicine, and by all odds, one of the leading thinkers for decades now about healthcare workforce. He's a pleasure to work with all the time, and Fitz is a member of the IOM committee that I'm co-chairing with Gail. Karen Davis is with us. Karen, well known to all of you, is president of the Commonwealth Fund. She's an economist engaged in really leading thinking, not just in the US, but worldwide, about healthcare and healthcare reform. I've learned a ton from my ongoing colleagueship with Karen and her achievements as a thinker and leader in helping inform what we are calling healthcare reform all over the world, is second to none. David Blumenthal is next to Karen. David served as Chief Health Information Innovation Officer at Partners Health System, serves there now, and is the Samuel O. Thier Professor of Medicine and Professor of Healthcare Policy at Mass General Hospital. From 2009 to 2011, overlapping with my service at CMS, David was the National Coordinator for Health Information Technology under President Barack Obama. I don't think anybody in America has had bigger impact than David in what is now becoming a really welcome and stunning acceleration of modernization of health information systems in the U.S. My hat is off to David for what he achieved in that job. And our first panelist, and to my immediate left, is Afaf Meleis. Afaf is the Margaret Bond Simon Dean of Nursing, University of Pennsylvania School of Nursing, Professor of Nursing and Sociology, and Director of the school's WHO Collaborating Center for Nursing and Midwifery Leadership. Afaf is a leader in thinking about nursing and about women's health and women's issues in the healthcare scene worldwide. Great pleasure to get to know her. And Afaf, you have the first word.
Thank you, Don. Good morning, everybody. And it's such a pleasure to be on this panel with such a distinguished group of people. And I'm really looking forward to the dialogue from our audience. And as we frame the dialogue, I hope we think about 2 things that are really important in this country and globally, and that's health disparities and diversity. And in particular, I'm really interested in gender inequity and how it plays for the providers of healthcare and for the recipients of healthcare. And the second is framed by Dr. Frank this morning, and that's transforming education for the future. So I hope this will enter into our thinking about the issues that we're going to bring up and some of the solutions that we will think about. One of the things that came out from our report, our Lancet report, and Dr. Frank discussed it this morning, is that we need to start with the population if we're going to think about what kind of education and how we transform education. So my role is to just set the frame in terms of some trends that are going on globally that we need to take into consideration as we think about the workforce need, which is going to happen all day discussion today. So I think it's for the first time in recorded history, people age 65 and over will outnumber children under the age of 5. As we heard this morning, life expectancy is increasing, and it's in response to wonderful knowledge development and science. But also, old age comes with lots of challenges. World Health Organization said that by the year 2025, the global population of people 60 years and older will be 2 billion. 2 billion. Currently, it's 650 million. What happened? It's as we grow older, we have fewer children to take care of us. We have increased burden of disease. We have fewer options for care. We have more cost. We have strains in terms of long-term care. And women are the largest cohort of elders. They suffer disproportionately from poverty, isolation, poor health, and from discrimination. In fact, in the United States, older women outnumber older men. And women who are 50% of women over 75 years of older, they live alone, and they also live with, they live on Social Security. Now, we've always thought that this is happening only in the developed world. The aging is a global issue and comes with many global challenges, and we need to be learning from each other and working with each other. It demands long-term care, it demands geriatric specialists, home health programs, specialized programs, innovative programs to deal with that. So the questions that we'll deal with are, who will take care of these elderly people in the United States and globally? How do we incentivize women and men who go into nursing and medicine and dental care to focus on the elderly? Because there is a lot less focus on the elderly now. Who takes care of the family members who are the caregivers, who are strained and stressed? Have we invested enough in developing, testing the best models of care for people to age at home? Because lots of people want to do that. Gerontology care, home care, daycare, accessible care are needed, and they are not there, and there are very, very few programs for that. Are we prepared? I think the answer, we are not. So the second thing, that's issue that I'd like to bring forth in terms of the population is a second driving force for what we need to think about is the urbanization. We talked a lot yesterday about urbanization and its effect. We did that in our Global Health Interest Group. So it's expected by the year 2030, 2/3 of the world will be urbanized. Great. Urbanization brings so many wonderful opportunities, better education, maybe access, opportunities, different choices. But it comes with lots of challenges. Housing issues, public transportation issues, water sanitation, food security, safety and violence, lack of access to quality health care. 32% of the population who live in urban areas live in slums, favelas, shanty houses, and both the developed, the developing world. Sometimes when we say these things, people think we're talking about the developing world. Well, we have developing world in our own backyards in every city in this country. When there is a public transportation problem, when there is no public transportation, there is limited access to work, earning power, education, and health care. When there are no walkable areas and no places for physical activity, we see hypertension, diabetes, obesity are problems. When there are limited lights for safety in the streets, safety is compromised, violence and injury are increased. When roads are constructed for cars and when they are not constructed for people, they are constructed for cars and for speed, not for people, not for bicycle, not for walking, not people. People tend to have more injuries and more accidents. When we have no access to connectivity, there is stress and isolation. And when there is no fresh fruit and vegetable, there is junk food. There is air pollution and all that come with urbanization and communities. So I said that 32% of the world urban population lives in slums. 70 to 80% of those happen to be women. Women-headed households are becoming more common in urban areas, making up an average of 20% of of households that are single women-headed families. Urban areas are not built to respond to women's needs nor to the elderly needs. They are built without the voices of public health people, and they are built without the voices of women who are the center of the family and the center of the community. So that's the second issue that we need to be thinking about in the future. The third one comes with it, chronic diseases. We're increasing aging, and urban population leads to lots of chronic illnesses. Chronic diseases here in the United States, heart disease, cancer, diabetes account for 7 out of every 10 deaths among Americans each year. And the greatest increase is expected to be seen in low-income, middle-income families who have limited access to health care. With all the negative effects of also globalization and movement of population and urbanization, it becomes even more issue. Again, we need to look at the growth in chronic illnesses from a gender perspective and through gender glasses. Heart disease, cancer, stroke are 3 leading causes of death for women in the United States. Women face more increased risk of communicable disease and infections in the slum areas and in the poor areas. Of course, vulnerable and disadvantaged people get sicker, they die sooner. They also have disparities because they can't work, and they are costing us far more. So I propose that we think about, as we think about what we need to be doing about the education of health professions for the future, that we need to start from a framework of equity and justice in terms of resources, equity and justice in our educational programs, in whatever it is that we are offering out there. Primary health care gets mixed up with primary care. Primary health care is not primary care. And I think this mixed up languages makes us not really prepare our students in all fields for primary health care, which is community-based. With urbanization, increasing urbanization, it's community-based. Team building that's needed to take care of all those issues doesn't happen after people graduate. It happens as you build that in the fabric of every school and the fabric in the life of people as they come into our education. So we need teams to take care of those urbanized people who live in the community, who are elderly, who are chronically ill. We're moving out of the hospital. And we need to be thinking about developing innovative programs and testing the innovative program. We have no data related to that, and that's an area that we need to look at in the future.
Thank you so much, Afaf. David.
Thank you, Don. Thanks for your kind introduction. It was a great honor to serve with you in the government as we overlapped. And I also want to echo your compliments to Julio and Harvey for their terrific framing remarks. I'm going to expand a little bit on an important point that Julio made about the change in perspective on education and its roots in the 21st century, and that is the idea that education should be driven by the needs that are created by the healthcare system and the populations, and be competency-based. And those competencies need, in some sense, to be matched to the needs that are created by people and systems. We've been waiting for decades for fundamental changes in our healthcare system, fundamental changes that would ameliorate our deep-rooted problems, and perhaps it's overly optimistic to see that we are reaching a tipping point, but let's assume for the moment that in fact some of the trends that we are seeing are going to continue and accelerate. What are some of those very important trends that are going to create the need for new competencies? I think there are 3 of them that I'd like to emphasize. There are many more, of course, but 3 that I want to call out. The first is the increasing demand for accountability among health professionals for their performance. The second is the changing organizational situation in which health professionals increasingly ply their trade. And the third is the demand for and the need for a new approach to information and its management in an age of exploding and unmanageable information. So let's dwell a little bit on each of these. In terms of accountability, I think there are several forms of accountability that will be demanded of health professionals in the next decade. One is for stewardship of resources, for understanding the economic implications of choices. In the words of the American Board of Internal Medicine, for choosing wisely when they choose and recommend treatments to their patients and consumers. In that regard, there may be support through electronics, and we can talk about that a little bit later. The second is for taking into account the value of the care provided, its quality and safety to start with. There are many aspects of daily work that do not receive much attention right now that are integral to quality and safety. Most of them have to do with increasing the reliability of the systems in which health professionals practice, the reliability of very mundane but important things like handoffs from one set of professionals to another, the reconciliation of medication lists, the assurance that transitions of care and the exchange of information occurs, all very basic but absolutely integral to quality and safety. The need for stewardship of resources in particular will raise new challenges that we must deal with better now than we did in the managed care era related to the ethics of practice. It's been extremely comforting throughout the history of medicine to assure ourselves that the patient in front of us always comes first without trade-offs required, but we know that's not possible in an age of limited resources. So helping health professionals manage those difficult ethical issues in ways that are practical and actionable will be a huge challenge for the 21st century. One of the challenges in creating this accountability and in teaching it is the very fact that our faculties are not prepared for it. Our faculties are not trained or educated or comfortable with role modeling the behaviors that are necessary to deal with these issues. And I see that every day in my own health system, and I am sure it is widely prevalent throughout our health system. So that's a challenge for the educational establishment going forward. Talking a little bit about the organization of care now. We will always have small practices of medicine and other health professionals in the United States, but it's undeniable that there is a consolidation of care right now. The proportion of physicians who are self-employed is declining at a rapid rate. To live and work in organizations requires different kinds of skills. There are many opportunities that organizations can create for health professionals, but those opportunities can only be seized by people who are prepared to work with colleagues and in organizational settings. Interpersonal skills, which have never been as prized in the health professions as they ought to have been. Teamwork, we've heard a lot about teamwork. Teamwork is a great opportunity in organizations. It can also be ignored to the detriment of all concerned. Knowing how to participate in a meeting and lead a meeting. Two basic skills that I never learned in medical school and that are too often lacking among health professional colleagues. And then leadership at every level. Organizations need leaders at every level, and health professionals need to have the skills and the preparation to provide that leadership. Let me say a word about information management, obviously a topic that's been important to me professionally. Information is a precious resource for clinicians. We take it for granted that it's present, but it's not something we can take for granted. We are paralyzed without information about the consumers and patients we care for. Good information can make the difference between good performance and bad performance. But we manage, collect, and store information in the United States right now, for the most part, pretty much the way Hippocrates did 2,400 years ago. And we expect to have a modern healthcare system. Technology can be a critical resource for managing the explosion of information. If we're going to talk about personalized information, personalized medicine, we're talking about managing information to tailor it to the needs of a person. That cannot be done given the explosion of information with the human brain as unsupported human brain. There's just simply too much to manage. Those technologies themselves are changing at unprecedented rates. Tom Friedman tells a story that when he went back to look at the index of his 2003 book, The World is Flat, and looked under F, there was no entry for Facebook. There will be many generations of Facebook in the next 10 to 20 years. People talk about how my generation is handicapped for its lack of sophistication with technology. I feel sorry for my children because the rate of advancement of technology will be even faster in their generation, and they will be left behind even faster than we have been. So the ability to manage information and to manage the technologies that are available to help with the management of information will be another core competency demanded of future health professions. And I don't think we have found ways yet to organize and integrate those skills and to prepare people for lifelong learning in the presence of that kind of explosion of information and technology. So those are some of the thoughts that I have. I'm going to get a bonus from Don because I'm going to finish early. But I think it's an exciting time with many opportunities and huge challenges. Thanks very much.
Well done, David. Thank you.
Thank you. It's a thrill to be on this panel with colleagues whom I admire so much. I was so excited at the turn of the century. I thought it would trigger a lot of thinking about the kind of health system we would like to see and how to get there. And I was a bit disappointed that we were mostly fixated on would computers work in Y2K. So with colleagues, I wrote an article in the Archives of Internal Medicine in 2000 called A 2020 Vision for American Healthcare. And that really had 5 components. 1, universal health insurance coverage. 2, access to care, everyone having easy access to primary care practice that would be patient-centered and meet a number of other characteristics. 3rd, that we would align the incentives in our healthcare system to reward the kind of system we would like to see. 4th, that we would have information-driven care, everything from adoption of health information technology, clinical support systems, but obviously evidence-based care being brought to the practice. And then finally, that we would have innovation and quality improvement, and that every single member of the healthcare workforce would be committed to adopting the very best practices and continuously improving the quality of care. I've been privileged over the last 2 decades to work in American philanthropy along with foundations like the Robert Wood Johnson Foundation, California Healthcare Foundation, Macy Foundation, Kaiser, Hartford, I'm going to forget someone, but obviously being at the Commonwealth Fund. And what I've really come to believe, if we would simply apply 100% of the time all of the things that we know that would improve care and improve the performance of the healthcare system, the U.S. truly would have the best health system in the world. And I just, thinking back over some of the things we funded and others have funded, wanted to tick off what I think some of those tools in the toolbox, and I'm borrowing this from David Blumenthal's image, in 3 areas: primary care, payment reform, and health information technology. In primary care, I think we learned from Barbara Starfield, among others, the importances of providing comprehensive services, not just being a referral to specialists, the importance of having a defined patient population, a panel of patients, and being proactive about eliminating any gaps in care. Very impressed by the Kaiser Permanente system of identifying when somebody is not up to date with a preventive service, not on track with management of chronic condition, with primary care practice being committed to eliminating those gaps in care with use of things like disease registries, preventive care registry. Also within primary care, privileged to support work on systems of off-hours care, how to in fact have 24/7 coverage and have that link to one's own source of primary care. We had a session yesterday focused a lot on the importance of care management nurses within primary care practice, focused on the high-risk patients who are most amenable to intervention with care coordination and case management, the importance of team care, delegation of tasks to be able to meet the needs of patients with the appropriate competency. Very intrigued by innovations in real-time specialist consultation for primary care clinicians, specialists who don't have to see the patient to be able to advise primary care clinicians real-time about how to handle issues, as well as innovations in home telemonitoring, support for health behavior change, as we've heard mentioned a little bit here, the integration of primary care and mental health care. I think that's a beginning. Others can fill in a lot of innovations in the way we organize and deliver primary care that would lead to better outcomes, better experiences for care, and lower costs, to quote the triple aim that Don really imprinted on our thinking. Turning to payment reform and professional incentives to reward the kind of care we would like to see, certainly recognition for excellence. As patient-centered medical homes had a chance to chat with Bob Galvin this morning, who with Bridges to Excellence, I think really began that, and then Peggy O'Kane at the National Committee for Quality Assurance. The recent implementation of 4- and 5-star incentives for Medicare Advantage plans, value-based purchasing, all of these ways of, through recognition or financial rewards, trying to promote excellence in care. Maintenance of certification in many of the specialties now tied to continuous quality improvement. The creation of the centers under Don's leadership, the Centers for Medicare and Medicaid Innovation, testing demonstrations and pilots of blended or global payment for primary care, value-based purchasing for primary care, patient incentives to enroll in primary care practices that adopt these techniques, or accountable care organizations, as well as global payment for accountable care organizations and shared savings and bundled payment methods. Finally, in the health information technology, David has ticked off a number of those, obviously electronic medical records, electronic prescribing, medication adherence. So I was struck by Kaiser's experience that 20% of patients didn't pick up the prescription, even though it was free and ready for them as soon as they walked out of the practice. How can we use information tools to know that that's going on and deal with it? Clinical decision support, disease registries, health information exchange, patient portals, being able, we just saw a study this last week on the importance of patient direct access to medical notes, how many people don't hear what the doctor says, the importance of visit summaries, so that they walk out of there knowing what's transpired, as well as access to their records. We've been pleased to fund work at Group Health Cooperative. See Eric Larson in the audience on shared decision making, and how that tool can lead to more informed choices of alternative treatment methods, patient and family engagement linked to community resources. So anyway, everyone in this audience can fill in a lot of things that I haven't mentioned, but those are the kinds of tools where if we would adopt those best practices everywhere, we could have marked performance. Don said, okay, so tell us in 2020 then what that would be and what the gains would be of trying to adopt best practices throughout the system. So this is where I leave evidence-based and go to aspirational thinking, although some of this is based on modeling work that we have funded. My vision is that in 2020, if we did all of those things, we would have 98,000 fewer deaths a year. All of you know that was the key number in the Institute of Medicine to Err is Human report in 1999. But it's actually also exactly the number of deaths that would be prevented if the U.S. had the same mortality amenable to medical care as the best countries in the world now. So if in 8 years we simply got to where the best countries are now, we would save 98,000 lives a year. We would keep health spending at 17% of the gross domestic product, despite an aging population and more needs. We would do that through productivity and efficiency gains. That would save us $2 trillion a year if we could keep health spending growing at the same rate of growth as our economy. We would have 95% of the population covered. Again, I think what we are projecting under the Affordable Care Act, if implemented and on the books, make care affordable, make coverage affordable, having fewer than 5% of the population who are underinsured. I think as we get insurance coverage, we'll worry more about the affordability and the adequacy of that coverage. I see a world where 95% of people are enrolled in advanced primary care practices that adopt these techniques of patient-centered care. I'm a little less ambitious, maybe I should be more ambitious on preventive and chronic care, but seeing that only half of Americans are now up to date with preventive care. My goal by 2020 is 75% of Americans will be up to date with recommended preventive care, and that 75% of all chronic conditions are well managed. I'll be pleased if we exceed at that. That we will have elimination of racial and ethnic disparities. I'm not willing to settle for 95% there. So elimination of racial and ethnic disparities. David has done a wonderful job moving this nation on a path toward modern health information technology. I had 75% meaningful use of electronic health records. Again, maybe you're more aspirational than that. And then finally, that 95% of patients would recommend their healthcare provider to family and friends, and that 95% of the healthcare workforce would recommend their organization as a place to work. So that's what I see as achievable by 2020, if in fact we will apply the science that has been so well developed and that we know how to apply.
Thank you, Karen. And Fitz.
Well, thank you, Don. It is a privilege to be on the panel and share ideas with my distinguished colleagues. Karen has provided a very nuanced, highly defined view of 2020. I'm going to go back up, maybe not to 40,000 feet, but at a higher altitude and look at the world. I've had the good fortune to engage workforce and education issues both domestically and globally. And I thought I'd try to share a little perspective, at least as I have experienced it from that angle. And I'm going to touch on three issues: the demand issues, the supply issues, and the accountability issues. In terms of demand, it is no secret, demand is with us. It's been with us in the developed world, I'll call it the global north, for some time. It's certainly with us in the United States and rising steadily. In the lesser developed world, or the global south, demand has been a luxury that has not been so easily afforded there. And there are, of course, medical education, health profession education institutions, but they're relatively smaller, and the systems that they feed tend to address the needs, the medical care needs of a smaller sector, the politically and economically more able in those countries. The 21st century, I believe that's going to change. It is changing, and certainly by 2020 it will be changed. And the basic flow here is better economy leads to more demand, leads to a desire to train more and retain more. And that's really the point I want to make around demand. In the global north, and certainly in the United States, we've relied on doctors, nurses, pharmacists from the world at large to make up for our educational shortfalls. And that's been a fairly easy proposition in the sense there are many able and ambitious people around the world. I think that's going to be less true in the future as the Indian subcontinent, for instance, begins to address its huge backlog of issues, and as the economy of India moves forward. And even in Africa, where I work a lot, you have countries with very modest resources and a modest health professions structure, laboring now to both produce more and retain more. So the dynamic of migration, I think, will be altered, and I think both abroad and here, the term self-sufficiency, the concept of planning and educating for what we anticipate our needs will be a much more important proposition. On the supply side, we have over the 20th century done a good job of following really the Flexnerian model of improving quality and standardizing quality in health professions education and in the system that surrounds it. So we now have elaborate systems of licensure, of certification, of specialization, and of professional delineation. That actually began to break down in the United States in the 1960s with the advent of the nurse practitioner and the physician assistant, a movement now that is bit by bit capturing the world. Of course, abroad, there have been various types of professionals called differently in different countries: clinical officers, nurse clinicians, technicos or technical officers that have occupied this mid-level of practice. And those are receiving much more attention. The PA concept is now moving fairly swiftly in Europe and Australia, South Africa. So the workplace of the future really, and I guess put with that, the notion that doctors will meet all of the need, the notion that the physician will be the answer to healthcare is just simply not possible. It isn't possible here. We're struggling with that. We have 280 physicians per 100,000. It isn't possible in India with 60. It isn't possible in Mozambique with 2. It's going to have to be a team that are laying on hands, not simply the physician, which has been the notion in many sectors for so long. The concept of task shifting, which the WHO really worked up and published as a concept in 2006, is friendly to this, the notion that people in our parlance should work at the top of their license and that we should shift tasks to lesser trained groups of workers whenever possible to get the most efficiency from the system. So I think a principal characteristic of the world of the future will be, at least at the what I'm calling the clinical or the hands-on care sector, will be integrated with a non-physician clinician, the term nobody likes but covers that whole sector, as a prominent player, both here and in the developed world, as well certainly as in the developing world. And finally, the issue of accountability. In the 20th century, we had prodigious growth in clinical science and health benefits and health costs, so that both the schools that we produced are costly, and the system, of course, is very costly. The result has been that only people of economic good fortune have benefited directly from that. In smaller, lesser developed countries, we talk comfortably about political elites or elites, but in fact, in the developed world, there has been a gradual movement towards more comprehensive coverage, greater universality, but still the more elite folks in terms of income, wherewithal, have benefited most. And that, I think, is going to become more under much greater scrutiny. The notion of universality, not just the rhetoric, but the implementation of it, is abroad in the world, and now is a political force where emerging economies are going to want, and their populations are going to demand health care, medical care, and that will be a challenge. And there are responses to it. Healthcare reform, goodness knows in our country, is a response to that. Globally, the notion of scale-up of human resources for health, those are the operative terms globally, has many manifestations and many actions or activities going on towards it. And certainly the Health Professions for a New Century that was so ably framed by Professor Frank tells us, or provides us with a framework to think about that. We have new language, fortunately, and new approaches to it, transformative or transformational, social accountability, and a term that gets used in conversation a lot and sometimes in policy documents, relevance. What is the relevance of a medical school or a nursing school or a pharmacy school to the needs of that locality, that region, that nation? That connection or that question is being asked more and more frequently, and I think to the extent certainly that health profession schools are publicly supported, this question will be an inescapable discussion among politicians and health professions educators and the civil society at large. We also have new perspectives which are helping. the health system strengthening concept, which invites the health profession school to be an active front-end participant in health system strengthening, kind of frames the challenge. Health disparities are now well established and appreciated not only as a policy and operational issue, but even as a research issue. What do we do to reduce health disparities? Social determinants of health feed into this more globalized universal concept of how do we get people healthier in a more strategic way, which will call on accountability. What is your enterprise, your school, your clinic, your practice doing toward that end? So I think the social mission of public and even private health profession schools will be a central feature of institutional identity going forward in a way that it has not been as much in the past. In summary, demand is with us. Self-sufficiency will be an important element of dealing with that on a national basis. I think we'll see a more variegated a team of clinicians providing what previously was called the practice of medicine. I think the team will extend and should extend through the whole spectrum of health disciplines, but certainly the doctor will not be the doctor, it'll be the clinician and many different training routes. And finally, there will be a push towards harmonization between health professions training and population health needs.
Thank you, Fitz. Well, that was terrifically sweeping set of predictions in the crystal balls of my panel, ranging from global ethics, universality, macro issues from Afaf and Fitz especially. David talked about organizations and context and some of the circumstances of practice, and Karen a lot about the design and delivery and performance of healthcare. That covers the waterfront. I was asked to take my own medicine and give my own predictions. Unfortunately, my panel has trumped me. There's nothing original I have to say. A couple of framings I'll offer just as I've thought about it. One is I have come to wonder whether the face-to-face encounter is itself going to become a bit of a dinosaur. There are so many other ways to get help that centering healthcare on visits strikes me as in play now. A second is just to reinforce this momentum toward chronic illness and team-based care, which then brings us into the field of non-physician participants in the healthcare delivery system. Something you didn't raise, none of the panelists did, but occurred to me in preparation was the nature of risk in healthcare finance. I gather, if I'm not, this is my area, my area of science, but we're so much better now at predicting individual risk. That's only going to increase probably pretty quickly between now and 2020. And the whole actuarial model that healthcare is insurable, that moral hazard is a problem, that blindness to one's fate is useful in the financing scheme, it doesn't wash anymore. And the fundamental premise of insurability in healthcare seems to me to be a bit in question. That's an amateur economist and an amateur geneticist speculating. So we've heard quite a range of things. I was able to track 12 topics over 12 predictions: aging, urbanization, the surge of chronic illness is the fundamental challenge, all sorts of vocabularies around accountability. David's analysis of new organizational formats that young people and entering professionals will have to accommodate to. Sixth is everything about information, changing the information environment, and to use Karen's term, information-driven care, which I think is neat. There's a lot about alignment of incentives in various forms. The surge of primary care is the center. There's Karen's framing of I think she used the term 100% application. Could we actually imagine that all of the wonderful stuff that's going on pocket by pocket would ever be assembled into a high-performing system, to use the Commonwealth Fund's challenge? There's Fitz raised issues about surge in demand and the consequent demand on effect on supply, and then the framing of universality as a fundamental assumption globally, which will be kind of neat if we actually get to that point. There's a lot in play. So I've been asked in the design of this to just stimulate a little bit of conversation among the panel, then we'll move to the audience very quickly. I have a couple questions that I can't, I don't have enough self-restraint not to ask. If I were to summarize everything you all said and then look at the shape, at least in America, of the preparation of the workforce, maybe this is wrong, but it seems to me that the preparation of young professionals, at least physicians and largely nurses, is hospital-based. We are focused on, you get through the first part of medical school, for example, then you go into the hospital. Same for nursing training. Very little that you are predicting reinforces the concept of the hospital as the center of training, at least logically. Are you willing to comment on that?
Yeah, I actually want to turn to Karen with your predictions and the rosy picture that's going to happen in the future. What do you think about that? Part of that is not, all that is not going to happen unless we focus on community care. That's one. And the second part of it, so community care, we talk about primary care, and primary care is still hospital-based, but primary health care is really community-based. And that's when I mentioned the aging and urbanization, that's what we're heading toward. But the second thing that is sort of the elephant in the room is that there are only 16 states in this country that allow nurses to practice up to their full capacity. And so access to health care that you're talking about that's going to happen in 2020, could it happen without allowing nurses as partners practice up to their full capacity? So I was hoping that this would be part of your prediction by 2020, that this is going to happen in all 50 states.
Friendly amendment.
Friendly amendment, right?
I think, Don, your comment harkens back to what many in the audience, I suspect, will know, I hope know, the Carr White's nested boxes of 1961, which were replicated by Larry Green, who's with us today, in 2000. And what Dr. White did at that time was he looked at the American population, 1,000 people in a month, 750 would experience illness, 250 would see a doctor, 9 would be hospitalized, 1 would be hospitalized in an academic medical center, and that is where all the teaching goes on, in that one nested little box. And Dr. Green replicated that with much more robust data, and it basically came out the same in 2000. So this is a golden handcuffs we have to break through in some fashion. And of course, it's cheaper to teach in the hospital, at least in terms of medicine, which I know better, because you have a critical mass. Rounds are relatively inexpensive with 6, 8, 10 people on them and 1 professor. When you go ambulatory, and certainly we go ambulatory in the community, the teacher-to-student ratio becomes much closer to 1-to-1 and therefore much more expensive. So this is something that needs really good strategic thinking in addition to policy wishes.
Great. Well, I just would want to keep the door open on this conversation. After all, our most audacious interventions, our most vulnerable people physically, the technologies that are the hardest to use, they're concentrated in hospitals, and one would not want to lose a grip on the excellence of performance there. But what do you think, David, about this?
So I was tracking your latest thought. 2 things. The balance of care and teaching is distorted. There's no question about that. It's excessively concentrated in the inpatient side and excessively oriented towards specialization. And I assume that's true in non-medical, non-physician training as well, though I don't know that as well. At the same time, we don't have the capacity right now to educate the workforce we need in the community. So we have to manage a transition, if there is going to be such a transition, carefully. And we also can't neglect the fact that demand for care, advanced care, still exists and will grow. And that's part of the chronic disease spectrum. And that we're going to still need rheumatologists and endocrinologists and diabetologists and neurosurgeons. So that we just can't tilt entirely in one direction without thinking about the need to modernize education of our specialists as well.
I think your point about moving away from face-to-face encounters or visits as the unit of care to talking about care for the whole patient over the continuum of care, everything from population health, primary care, acute care, post-acute care. In my mind, there's no question it's easiest to provide care across the continuum of care if all of that is within a single organization, an integrated delivery system with a defined set of patients. Everything you talk about, team approaches to care, task delegation, information systems that are accessible to all of those who are touching this patient, accountability, to me, is easiest if we could evolve to that. So how we really make those kind of systems, putting the patient first, really having mission-driven care that is dedicated to the triple aim, I think will be the challenge in the coming years.
Let me dig one level deeper on your last comment, Karen, and then we'll turn to the audience. It has to do with the patient-family role in active care. That's not something we touched on directly yet. Kaiser Permanente has this wonderful phrase to its 21st century care design, home is the hub. We've seen lots of innovations, I've seen them through the eyes of IHI, in people taking control of their own care. I'm not talking about incentives, I'm not talking about cost shifting, I'm talking about simply moving what would have been reserved to professions into the hands of people to take care of themselves, even with rather serious interventions. My colleague Maureen Bisognano here today has been really championing the past couple of years the new role of, maybe we don't even need to use the term patient anymore, people in the system. Is that relevant to your vision?
Can I just respond to that? Because we are shifting the care to the families, and the families need care themselves. So I think that's burdensome for the family too. Patients leave the hospital with acute care needs, and they fall in the crack between the care that was going in and family who are not able to do that. So even if there is shift to care in the community, it should not be shift to care by the families only without getting support for the families. Mm-hmm. So the families are carers that need care too.
Anyone else? Well, let me invite you in the audience now to take control and steer us in the right direction. I'll try, the glare is a little hard to see, but I'll circle around. Go ahead. Could you just introduce yourself when you ask your question, please?
Yes, I'm Michael Larimore. I'm the Dean at the School of Veterinary Medicine at UC Davis, and I really appreciate the conversations and the concept of transforming healthcare in the communities, and I think as we look at the global community, certainly a member of that team, especially when we're talking about infectious diseases, and also a critical issue which wasn't brought up is food safety and security, is veterinarians. And I know it's one of our goals to really look at that human-animal environmental interface. And I think that's another thing to keep in mind as members of the team, especially as we go into communities, is that role of the veterinarian.
Thank you. In the back there?
Yes, Judy Stern, University of California, Davis. It's a conspiracy. I'm concerned because the nutritionist is continually left out of this group, and he or she often has a lot to bear, and the current team doesn't have that knowledge. Please comment.
Any of you have experience with the issue of nutritionists or nutrition in teamwork?
Well, clearly, in terms of the family of health professions, nutrition is both as a profession key and as a concept key. And it probably has deserved the status for the longest running orphan in the team, in the sense of decade after decade, the issue is raised of why don't we get better, why don't the rest of the team get better training in nutrition and be more nutrition smart? And I don't know the answer to why, but it has remained with us. So I certainly salute the idea that, that nutrition is a very important part of the health professions team.
Can I just say, I really appreciate your comment. And at the School of Nursing at the University of Pennsylvania, we have 3 professors in nutrition because we believe that's really part of being community-based and primary health care, that we have to have our colleagues' nutrition as part of the school.
And I have a joint appointment in the School of Medicine also, but I think we're in the minority. I know we are, in terms of schools.
Thank you.
Thank you.
Herb.
Yeah, thank you, Don. Thank you. Great panel here. First, a comment, Fitz. I think your illustration is not complete, because I'm sure you know that hospitals don't just take care of people who come into the hospital, but they have millions of people they see in outpatient departments, medical homes, and everywhere else. So I think that addition might be important in framing your statement with regard to where people go for care. The question I want to ask, though, is I believe a low priority issue for decades in this country has been mental health care. And my own opinion is that it was decimated back in the 80s by some policy decisions that took the United States out of health care. On the other hand, we're increasingly aware of how pervasive it is, how costly it is, and then as we think about how to deal with it, it's either better primary care into mental health or better mental health into primary care. And I'd appreciate comments from the group about how we approach this.
I didn't hear it. Was it mental health?
Mental health, behavioral
Mental
health.
health. Well, I think when the definition of primary health care includes in it mental health, so which we are not definitely providing. And I'm with you that this is going to be a crisis coming up very soon, that we are not preparing enough mental health professionals to be out in the community or even out in our primary care, which is the clinics, to detect mental health and to deal with it. We wait for the psychiatrist or the psychologist, and that's not part of the team.
Herb, when I was in D.C., you came to my office and showed me some data I was not aware of about the economics of this, that I think for diabetes, a person with diabetes and depression will cost about 2.5 times as much next year as a person just with diabetes. Is that right?
Well, I don't remember the exact numbers, but if you just think of an anecdote, imagine the possibility of somebody who has both diabetes and depression. If the depression weighs on, what do they do in terms of their own diabetic care? We're seeing that across the board. Comorbid situations, mental health or substance abuse, plus a non-psychiatric or non-addictive healthcare problem is a very costly and formidable item.
It is a profound problem, I believe, Herb. Last week, I teach a course, a health policy course to GW residents. We had about 30 in the room, and we were having a session on behavioral health. And we dug down into what the medicine, pediatrics, OBGYN residents had in the way of preparation for practice. Not just what do you know about the DSM, whatever, but what do you know about referral? Where are you going to get help? Mm-hmm. And across the board, all of them said we get no exposure, no systematic discussion of how to cope with mental health, behavioral health issues in our practice. We're busy learning disease entities, but this question of mental health and what you do with it really was not a part. Now, that's just a limited biopsy, I realize, but that's a real concern I have.
Let me add to this terribly important problem, a profound obstacle to dealing with our quality and cost issues. Reflective, I think, reflecting back on the quotes from Kahneman this morning, reflective of deep-seated beliefs, not only in society but among our professionals, about what mental health problems consist of and how they should be managed. And I think until we tackle those beliefs about whether mental health and behavioral health are real illness or something else, whether they are the extent to which they stigmatize, all those things, I think we're going to have a difficult problem integrating behavioral and mental health services with physical health services.
The only thing I'd like to offer there is the example of the Massachusetts Child Psychiatry Program, where psychiatrists back up pediatricians, primary care clinicians taking care of children. When we have shortages, we're almost driven to those kind of models. But that idea of real-time consultation of specialists in mental health assisting primary care clinicians in dealing with these issues, I think is one of the promising models.
Another example I've been touting a lot going around the country is the winner of last year's Malcolm Baldrige National Quality Award, the NUCA system in Anchorage, Alaska, which is completely it's everything. We're talking about team-based, and behaviorists are on every team. They've got a 53% decline in hospital bed days and a 65% decline in specialty use in the 6 or 7 years that's been running. The back microphone.
I want to go back to Karen's point, which I think has got to be brought forward. and that is raise the question of how do we stimulate, lead, motivate consolidating healthcare systems to redefine themselves to more directly become involved in health professions education and clinical research, for that matter, because they're the new organizational form that offers tremendous potential, and we can't let this evolutionary switch in organizational systems pass us by as an opportunity. Gary Filerman, Atlas Health Foundation.
Do you want to comment on that, Karen? No. Thanks. Ruth.
My name is Ruth Lubick. I'm a nurse midwife and anthropologist. I'm also an honoree, a Leonhard honoree from 2001. So you've told me I'm a good girl. And, and before that, a MacArthur from 1993, which enabled me to come down to the district to try to see what I could do, or what we could do, what our model would do for the disparities in this country. And focusing mainly on African Americans because they have by far the worst disparities. I want to emphasize the importance of working with the community and in the community. If you, I don't say if you possibly can, because listening to all you folks, I got sort of depressed myself. I needed a little mental health care, I think, but
I can't hear her. Can you hear her?
But you know, in coming down here, I was going into a black community, and so I said to the folks when I would go around and try to make connections with them, now I know I'm the wrong color, and I'm from the wrong place, New York. Everybody knows New Yorkers are crazy, right? But that connecting, I think paid off. And I wanted to just give you some descriptive data, because in the year 2006, which is the last year that we had really a full black population, now our services are being infiltrated by middle-class professional people. But in that year, we were able to reduce the precursors to infant mortality, preterm birth, by 2/3, low birth weight by 3/4, and cesarean section by 2/3. Now, those are only descriptive data. But using proxies like the IOM's proxy for the cost of preterm birth, $51,600, just for the birth. That's not what the child needs throughout life. We were, and applying those to those differences, applying those proxies, we used EPA's proxy on cost of illness and the Wall Street Journal's numbers on cesarean section, because nobody will tell you what they're paid for cesarean section. But apparently we saved $1,600,000 some dollars that year. And we did that on 153 births. Now, what is the largest hospital admission in this country? A hospital discharge, it's mother and baby. So if you applied that even to all Medicaid families, which is what we were dealing with, think of how much money could be saved. So I thought to myself, wow, people are going to be really excited about this. But people were excited not positively, but negatively about this.
Ruth, I'm going to interrupt you because I want to make sure we get time for everyone. But let me take one of your points into a question for the panel, if I can. I think that several people use the idea of a challenge for preparation of young professionals is community-based learning, connection community. Is that realistic? Do we have models for doing that really would work?
Can I share a model?
Yeah,
I share a model. So at our School of Nursing, I think we are probably the only School of Nursing that owns a practice called Living Independently for the Elderly, LIFE. It's based on PACE. We take care of 450 elders in the community to keep them at home as long as possible, but take care of all their healthcare needs and all their social needs. So that is a model for education for medical students, nursing students, social work students, but it's also a model where we are providing care. It's Medicare, it's capitated with Medicare and Medicaid. So there are, and because we are interested in the elderly and what's going to happen to the elderly, so there are models that are community-based and they are home-based that are also helping to prepare students.
And Fitz, you were talking about these are relatively more expensive in
It's more
terms of
expensive.
ratios.
I must say there's a couple of models that are worth noting very quickly. We did a study of we called them post-Flexnerian medical schools last year. A number came to mind. The A.T. Still School of Osteopathic Medicine Mesa campus has a program now, has 2 classes of graduates. They do 1 year of basic science on campus, and the students get sent to one of 11 community health centers, FQHCs, around the country. They do their last 3 years, all their clinical work there. They use the local hospitals for their in-hospital training, and they've produced 2 classes now, heavily primary care, done very well on objective examination national boards. So that's a radical model, but there are many along the way. So I think there's a nascent community education movement in the country. It needs fuel.
Thanks. We're running short on time, and there are lots of lines.
Could I make
in the back.
I think we have to move on, Ruth. We got a lot of people that want to ask questions. So let's catch the panel.
Just wanted to talk about distance learning, which is something that midwifery is using, and midwifery has been around since
Okay, take a minute
the
and then
19 teens.
please.
Okay. Okay, she did.
Hi, David Vlahov, UCSF School of Nursing. And thinking about 2020, I want to go back and punctuate a point that you made, and that is the concept, just to use the term a little differently, citizen health. And that's the idea that it really is a population now that's getting access much more easily to a lot more information. How is that processed? How is that going to be utilized in the best way? It's self-assessment, to some degree self-treatment, and it's also access to the medical record. You know, Tom Daschle, who was here before, shows his iPhone and that he has complete access to his medical record. He's able to make additions to it, even corrections to the history in his notes. So I think, how is it that we're going to envision that and really build that into our clinical practice, but also into our professional education?
This is really a different image of professional activity, not violently so, but it's challenging, no?
So I think that vision is enormously powerful, and it definitely, I think we're moving toward a more, toward greater parity in control over healthcare between the professions and the populations they serve. We have a couple of obstacles to getting there. One is the fact that our systems for mobilizing that information are still immature. Another is that the demand for it is still not very high. It's high among certain very elite populations, but it's not high among the broad mass of people who see physicians and nurses and other health professionals on a daily basis. And until the demand is higher, it's going to be hard to create the infrastructure you need to make that information really available. So I think it's a work in progress. We have to also, I think, not attribute to everyone exactly the needs and desires that we in this room may have. There are still many people who like the idea of having their care in the hands of a trusted advisor and professional. Again, it's all a matter of balance, I think, over time.
Thank you. In the back.
Susan Scrimshaw, president of the Sage Colleges, hi, and a medical anthropologist. First, I want to thank every member of the panel for what you individually have contributed to this field. Second, I want to point out that our Health Commissioner Shah in New York State has already saved billions of dollars by implementing some of the primary health and community health principles in the last 18 months in the state of New York. And then finally, I had the privilege of being a member of the commission that Julio Frank described this morning, and we struggled with our definition of health professions. Afaf is nodding. Obviously, physicians, nurses, we included public health, and then we argued a lot about everybody else and decided it just wasn't in the scope of the report to be able to deal with everything. But I get a chance today to point out and to second Afaf's comment that, first of all, we haven't even extended privileges to nurses, and there are many categories of nurses. But when you move in this country to physician assistants, to nutritionists, PT, OT, clinical, community psychology, I can go on and on. There are many areas that we are still siloing away, and this is a tremendous challenge that we face. If we go international, then we're including midwives, community health workers, pharmacies, again, on and on. So I would just ask us to keep in mind that the job is not done if we only talk about nursing medicine and public health. Thank you.
Reflections on that?
Well, I take issue with I might as well say that now, I take issue with task shifting, because if we are focused on people, human beings, I think it's task sharing rather than task shifting. And if we are focusing on interprofessional connection, then we should not be talking about tasks. So that's one. And the second thing that I take issue with is the non-physician clinician, because that does not respect the rest of the professions who are very important for the team. So I wish we can take those two things out of our language as we speak about teamwork and as we speak about the future of healthcare.
Bob Blum from the Bloomberg School of Public Health, Johns Hopkins. Welcome back, Karen. I want to pick up on some of the themes that have been reflected in the comments and questions recently. What we have seen certainly over the past decade, both in terms of basic science and in epidemiologic research, is that the social conditions drive many of the chronic conditions. They drive many of the high-cost patients. I know in our context, what makes high-cost patients so very expensive is only in part their morbidities, their medical conditions, but the social conditions to which they go back into. And the same can be said about comorbidities and many of the other issues. So the questions that I have are really twofold. One, is there, in your vision, any sources of support and funding to address the social factors that we know so tremendously contribute to morbidity, mortality, and drive up our cost of health care? Two, is that what I've heard about is reshaping professionals, but what I think about is deprofessionalizing healthcare delivery. You talked a little bit, Dr. Meleis, about community-based health, and I'd be interested, is there any room for really building the skills and capacity of neighbors in community?
So question is funding and space for building capacity in communities?
I think very important point, particularly on supporting, for example, caregivers, family caregivers, really kind of shifting our thinking that it's about dealing with patients and dealing with whatever support that they have in their family. So of all of the social conditions, I think the first one I would start supporting, focusing on is the social support and how we can tap into those strengths. Yeah.
Yes.
Hi, Linda Freed, Dean at Columbia's Mailman School of Public Health. I echo my thanks for all of your work and a superb panel on a more than timely topic. I wanted to raise the question, which I think intersects with comments every single one of you have made, which is, what should we be thinking about for the public health system for the future? If estimates in the literature are right that somewhere between 50% and 70% of health are created through public health approaches, then attention to that and its intersection with every point that has been raised in this discussion is a very important thing for us to focus on. And if Karen is right, that in 2020, 95% of our population will have access to care, then that raises the question of whether we don't have an immense opportunity to actually envision a 21st century public health system that doesn't have to provide safety net medical care and can really provide a new kind of conditions for creating health. So I'd be interested in your thoughts about how a redesigned public health system as well as medical care delivery system should perhaps intersect and where the responsibilities might lie.
Fitz, you want to pick that up?
I'll take a crack at it. You raised, Linda, a very, very profound set of issues, I think, in terms of the role of public health. The more we move towards universality, the less the, I believe in the IOM report on the future of public health, it was the assurance function. That is, the public health ought to provide the stopgap if medical care isn't being provided. If we really have universality, that role diminishes. And the other aspects, which were policy development and surveillance, I think, if I have the right terms, would get more attention. I think that's a little simplistic. One issue I'd raise is that to the extent that we're shifting more public health responsibilities, which get into the whole prevention zone, we really need to be sure that our providers, that our clinicians are public health educated, public health attuned, which is not always the case. It's pretty spotty. Secondly, the question then of how one maintains support for public health, because in a lot of states and jurisdictions, it's the immunization clinic and the prenatal clinic and so forth that have driven things. And I think appropriately, if we're doing all that in the universal system, that would diminish. But then keeping the flag of public health flying in the eyes of state legislators and others becomes a challenge. There's a lot there, but that would be at least a couple of thoughts about it.
This is a painful job to moderate because we're almost out of time, and I see lots of people back there. So, Steve, quick question.
Right.
And
okay, quick one. Steve Short, Dean of School of Public Health at Berkeley. No one yet has really addressed what you think should be some of the common content skills across all the health science professions that could, in creative ways, be built into the time demands and so forth of the existing siloed degrees. And so I'll just put forward quick candidates and have you comment on those. If we talk about population health, epidemiology, the basic concepts and skills of epidemiology are relevant to all the health science professions. Human factors and systems engineering would be a second candidate. And a third really would be the behavioral and social sciences, that part in which there's an extensive research and evidence base on teams and team building and how to do some of that kind of stuff. And information management, that David, you mentioned, cuts across all three of those. So I'm told that the Mayo Clinic's medical school, for example, now requires a double major. You have to get a double major in medicine and systems engineering as one example of innovation, if that's correct. But I'd like to have the panel comment on that if they could.
an inventory of skills that need to be introduced.
Determinants of health care, the social determinants of health care. And I just want to link these two comments by saying I don't think we should, even going back to my urbanization, design cities without public health people involved in it. So there is health assessment, for example. So there are lots of common content that could be put together that involves all the professions.
Well, my red light is turned on, so I'm going to have to join me in thanking the panel.
It's a pleasure to meet you. Thank you, Don.
Thank you very much.
With my apologies to those who are still standing, what a superb start. Don, thank you so much. Afaf, David, Karen, and Fitz, and Phil for your wonderful introduction. We've got a lot of questions in play, and we have only one afternoon to solve them. So put your thinking caps on through the rest of the lunch hour as we come to it, and this morning, because we've got a lot of work to do together with our remaining panels this afternoon.